Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 546 of our pharmacotherapy series, which majors in bipolar disorder. This part of the series involves patient CNN from parts 544 and 545 of this pharmacotherapy series. About 6 months after discharge, CNN's mother calls, concerned that CNN has been complaining of nausea, vomiting, and diarrhea for several days. During the past few hours, CNN has become confused and has developed a coarse tremor and slurred speech. It has been 4 months since CNN's lithium level has been checked. The only change is that CNN recently started taking naproxen for headaches. What action should be taken? There is a strong possibility that CNN is suffering from lithium toxicity, which can occur acutely from an overdose or insidiously from reduced lithium clearance. Mild toxicity at levels less than 1.5 milliequivalents per liter causes feelings of apathy, lethargy, and muscle weakness accompanied by nausea and irritability. Moderate toxicity occurs between 1.5 and 2.5 milliequivalents per liter, with symptoms progressing to coarse tremor, slurred speech, unsteady gait, drowsiness, confusion, muscle twitches, and blurred vision. Severe toxicity at levels greater than 2.5 milliequivalents per liter can result in seizures, stupor, coma, renal failure, and cardiovascular collapse. CNN seems to be experiencing moderate lithium toxicity. She should stop any medications that can decrease lithium clearance and the lithium itself until instructed to resume it. She should be taken to the emergency department immediately, where stat laboratory tests, including a lithium level, electrolytes, and renal function tests, should be ordered. There is no antidote for lithium intoxication. Intravenous solutions should be started to ensure that CNN is hydrated adequately, and electrolyte abnormalities should be corrected promptly. Depending on the results of physical examination and laboratory tests, cardiac monitoring should be instituted and hemodialysis should be considered. Hemodialysis is used to shorten the exposure of different tissues of the body to the elevated lithium concentration and to lower the lithium level to 1 milliequivalent per liter. Mohandas and Rammohan suggest that candidates for hemodialysis include those with compromised renal function, severe, which is irreversible, neurological symptoms, acute lithium ingestions where symptoms are clear and serum levels are greater than 4 milliequivalents per liter, or a chronic toxicity where lithium levels exceed the therapeutic values with a clearly manifested clinical picture. After receiving lithium 1,200 mg per day for 1 year, CNN returns complaining that the lithium is slowing her down. She is tired and has gained weight in recent weeks and thinks that she is becoming depressed. In the examining room, CNN complains that the temperature is too cold. What is the most likely cause of CNN's complaints? What treatment should be instituted? CNN's symptoms are consistent with those of hypothyroidism. Lithium affects the incorporation of iodine into thyroid hormone, interferes with secretion of thyroid hormones, and may interfere with the peripheral conversion of T4 to T3, triiodothyronine. According to laboratory indices, the incidence of hypothyroidism in lithium-treated patients with bipolar disease ranges from 28% to 32%, compared with 6% to 11% in patients not taking lithium. Risk factors for lithium-induced hypothyroidism include female gender, family history of hypothyroidism or thyroid illness in first-degree relatives, weight gain, elevated baseline thyroid-stimulating hormone, pre-existing autoantibodies, an iodine-deficient diet, rapid cycling, and elevated lithium levels. For women, the first 2 years of treatment is a period of heightened risk as well as for any middle-aged patient starting lithium. Thyroid function tests should be ordered to evaluate CNN's current symptoms. If she is found to be hypothyroid, discontinuation of lithium is not necessary. She should receive levothyroxine in doses that normalize her thyroid function tests. Even if she has an elevated thyroid-stimulating hormone with normal levels of T3 and T4, low-dose thyroid supplementation may help to resolve her symptoms and prevent breakthrough depression. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 547.